While TB is curable, one of the first and most important steps in the care process is TB diagnosis. So we're here today on Talking TB to discuss TB diagnosis. Hi, I'm Ashna Ashesh. I'm a lawyer, a public health professional, and an MDR TB survivor associated with Survivors Against TB, which is a TB survivor-led collective working with survivors and experts to advocate for better person-centered TB care in India. And I'm joined here today by Dr. Prerna Arora, who's a senior research scientist at the PD Hinduja Hospital, Mumbai. Dr. Prerna, in our previous episode, we had talked about a little bit about the different types of TB. From the point of view of DS and DR TB, or susceptible and resistant TB, could you tell us the difference between the two?
Yeah. So drug-resistant and drug-susceptible TB are the two forms based on the type of medications that may really suit the individual. So when a patient is diagnosed with TB, the first test that we do is a CBNAT to check or gene expert to check whether the patient is susceptible to the first-line TB drug. That's importantly rifampicin. If a patient is rifampicin resistant, it's called as a DRTB or a drug-resistant TB. The next assays evaluate whether the resistance is to other drugs as well. So rifampicin, isoniazid, ethambutol, and pyrazinamide are the four drugs that are used for first-line TB treatment. If it's resistance to Rif and INH, then we go towards the drug-resistant TB. The panel of testing moves towards checking the susceptibility patterns for the second-line TB drugs.
So more specifically, how do you diagnose for DSTB and DRTB? Could you tell us specifically about what standard tests are recommended generally and the ones that are sometimes recommended but should not be used or are used only in specific settings?
Yeah. So any patient who's diagnosed or suspected to be diagnosed with TB, the first thing that we request is for a sputum gene expert and a culture that has been sent in to check whether the patient has mycobacteria or no. So the first smear assay will tell us whether the bacteria is there on a slide. The culture is where in the laboratory we give appropriate conditions on in vivo in test tubes to or in the midget tubes to check whether the patient is having the bacteria. So if there's bacterial load, the culture would turn up positive. There's a wait period of 3 weeks or 6 weeks for the culture reports to come in. We have CBNAT test, which give reports within 2 days or within a day now with extensive research and fast-tracked testing availabilities are being made available. CBNATs and gene experts are tests that can be given undiagnosed within a couple of hours or till the next day, which test whether you have the bacteria disease, the bug Mycobacterium tuberculosis, and whether is it susceptible or resistant to the most common first prescribed drug, rifampicin. So if the patient is rifampicin susceptible, the patient is a drug susceptible TB patient and may require first-line treatment for about 6 months. If the patient is rifampicin resistant, the patient is started on a drug-resistant regimen, which is expected or anticipated to go up to 2 years for treatment.
Thank you. So basically, as I understand it, based on the line of medication, which is either the first line, which is for drug susceptible, and then for resistant, you check if there is any resistance or basically the patient is not responding to any particular drugs of the first line. And that's how you're looking at susceptibility and resistant testing.
So if a gene expert report is saying rifampicin resistant, the patient is empirically started on a second-line regimen or a drug-resistant regimen, which is given until we have the culture reports available and a drug susceptibility test that is being performed on the culture. TB culture report can be made available by, say, 3 weeks or 6 weeks once a culture is positive. A drug susceptibility test is additionally performed, which takes 1 to 2 weeks more. So overall, when we go to see it's a period of about 8 to 10 weeks wherein the patient is given an empirical treatment of drug-resistant TB regimen. Based on the clinical condition and situation, the patient is assessed. Any modification required in the line of treatment is made accordingly. Once the DST reports are available, the final drug regimen is finalized and individualized for that particular patient based on the DST susceptibility patterns. So when we talk about DST, it is drug susceptibility test to check whether which medicine will effectively work for the patient. If a patient is susceptible to a particular drug, that drug is good to go ahead. If a patient is resistant, that drug will never work and cannot be given for that particular instance and infection.
Could you walk us through some of the barriers to testing and focusing on individual barriers and also the systemic barriers that exist in accessing TB diagnosis?
So, the initial first that comes in for the patient is the cost for the testing. So, we of course have government centers who perform TB testing free for the patients, but the reachability of the patient till the center becomes a barrier. Then, if the DRTB centers are not near around to the patient, if the diagnosis is delayed, the patient is trying to reach out and to reach on time and provide the appropriate sampling on time is essential. So there are a couple of factors that move around. The reachability of the patient with the reachability of the appropriate samples that have to be required or are required for testing. At times, patients are not able to produce adequate sputum for testing required to be done. At times, there are myths or misunderstandings that you need a blood sample instead of a sputum sample for a TB diagnosis. So, testing methods also are different. TB blood test currently a misunderstanding or a misconception between individuals is that if I get a skin test done or a blood test done, that gives that I am having the disease. So as we have discussed about the two types of TB when it comes on to latent TB and active TB disease, the latent TB is actually when the bug is already there in the body. So a skin test or a blood test will definitely show that you have that. Until you really are showing up the signs and symptoms of the active disease, you really need to do a culture test, an X-ray to prove that the bug is actively growing in your lungs, or the other symptoms or for extrapulmonary need to be looked out for an active disease conditions.
Thank you so much. In terms of barriers, does stigma also act as a deterrent? Are patients often afraid to get tested because of the impact that that kind of diagnosis can have on their,
Yes.
not just clinically, but also on their social life and their community support?
True. So there are definitely, the fear within the patient that if I'm diagnosed with TB, I would be socially isolated from the society. There would be verbal talks. I would not be having the same relation with my friends, with my colleagues in my office. I may be looked down. I may be called as a sick individual rather than a normal patient interaction. And because my treatment may go longer, it may just get pulled for longer durations on, or I will be socially inactive. I will be cut from the society. That comes in as a fear within the patient drastically to limit the patient to go for the correct testing at the correct time point.
So, log kya kahenge becomes a fear here
Exactly.
also. Okay.
Yeah.
Speaking of communities and individuals, we know there is stigma around TB, but what kind of role do you think awareness and individuals and communities can play in effectively diagnosing TB and helping to effectively diagnose TB?
At community level, the government has also initiated programs on screening and awareness education. There are volunteers who go and spread across, spreading the knowledge and information about TB, about what type of symptoms you may have, and when is it time to report to the doctor or to the center to come in for appropriate diagnosis. There are medications that are being provided by the government free of cost for the patient. So cost also comes into a factor really when it comes in with the patient, because the patient feels that TB treatment may be too expensive. It may be out of my reach. It may be beyond my capacity. I will not get better. I will not get cured. And it may just end up in a miserable state. So at community level, the social stigma needs to be relaxed down with the awareness that TB is curable. An individual besides me having TB needs more of moral support, more of a moral push that you get your medicines, you'll get better. You're doing absolutely good. You're having a disease, but it is curable. You can absolutely come over it. You can continue with your education, continue with your job, career, and move forward. So the moral support within the society is really essential. That would really play a vital role, to be very honest.
Thank you so much. While TB is curable, it is very, very important to get tested in a timely manner and to get the correct tests for TB. So, as individuals, what we need to do is be aware that if we're facing any kind of health difficulties or symptoms that we think might mirror TB, we need to seek out care from our health provider and get the right tests and take the treatment that is prescribed. As a society, let's make it easier for people to get access to TB testing instead of shaming them for having an illness that is nobody's fault. TB affects us all, and it's in our best interest that timely, correct, and high quality diagnosis is available to all persons affected by TB. Thank you.